presentation.
Great, thanks so much, Steve. So I'm Katie Zhang. I'm a cardiologist here at Washington University in St. Louis, and I'm really thankful to Steve and ICOS for the opportunity to speak to you all today about cardiac amyloidosis, some diagnostic and management challenges in the TAVR era. So, you know, some of you might find it kind of odd that we're talking about cardiac amyloidosis in a cardio-oncology setting, but I actually think that there's, you know, a really important overlap here. So clearly, light chain amyloidosis, which is a cancer, is a major cause of cardiac amyloidosis, and there's going to be a lot of cancer overlap in terms of the making the appropriate diagnosis in a cardiac amyloidosis patients. And then, of course, once we get to the treatment stage, a lot of collaboration with the oncologist. So there's that part of it, but also at one of the recent ACC Cardio-Oncology meetings, there was a really nice cardiac amyloid talk that generated a lot of discussion and a lot of questions from the cardio-oncology attendees. So I think it's clear that, you know, there's a really important need and a role to talk about cardiac amyloidosis as cardio-oncologists. And then secondly, before we get started, I want to thank and welcome Dr. Nishat Khatter to our webinar today. She is a cardiac imaging expert here at WashU as part of our Center for Valvular Heart Disease, and so she'll be guiding us through kind of the finer aspects of diagnosis and management of AS in this patient population. So welcome, Nishat.
Thanks, Katie.
Okay, so we'll start off with a case today. Get going here. So our patient today is an 87-year-old man who presented to TAVR clinic. His recent course started about 2 months prior when he developed progressive dyspnea on exertion, and he was admitted locally for IV diuresis. According to the records that were received, he did undergo an echo, which showed a normal EF, just mild LVH, and then moderate AS with the measurements given there. He underwent a left heart cath, which did show a stenosis of the RCA, which was stented, but no other obstructive CAD. And so because of this moderate AS, he was then referred to WashU for basically a TAVR evaluation. So just for some more background about him, he had a pretty extensive medical history. Hypertension, diabetes, hyperlipidemia. He had persistent atrial fibrillation, and then pertinently, he had a history of CVA with pretty severe right-sided hemiparesis. He also had stage 3 CKD and some lung disease as well. And you see his medications there on the right side. In terms of his physical exam, vital signs were overall pretty normal. He was tachycardic on room air. In general, he was ill appearing. He didn't really have any of our classic kind of, you know, warning signs of amyloidosis, no macroglossia. His JVP was just a little bit elevated and a little bit of lower extremity edema. And then, of course, he had the weakness on the right side, as we knew previously from his history. So then moving ahead to some of his cardiac testing, this was his EKG. He was in atrial fibrillation, but you can see that he had low voltages in the limb leads. He also has these Q waves in V1 through V3, which we know to be pseudoinfarct Q waves because we know from his left heart cath that he did not have a prior LAD infarct. And then here are some images from his transthoracic echocardiogram. We already see from the parasternal long axis view here that his walls are quite thick. He has a calcified aortic valve here that is not moving totally normally. Here's the aortic valve in short axis. So we see kind of calcification and fusion of these two leaflets. The apical four-chamber view again shows extensive thickening of the LV walls, left atrial enlargement, overall preserved LV function. In terms of his mitral inflow, he's an AFib, and his deceleration time is actually 250, so not terribly short, but certainly the E prime velocity was 0.8. And then in terms of his tissue Dopplers, he did have kind of a low septal E prime, 0.05. And then moving on to his aortic valve assessment, you see that his mean gradient over the aortic valve was only about 16. And when we look at this in combination with his LVOT measurements, his dimensionless index was 0.30, and his aortic valve came out to be 0.9. So this is all consistent with paradoxical low flow, low gradient AS in the setting of his preserved EF. And then lastly, he did get strain imaging performed, which showed, a pretty, not perfect, but a pretty nice apical sparing pattern of longitudinal strain. Moving on to some of his initial lab work, his basic metabolic panel was notable really just for a mildly elevated creatinine at 2.0. His liver function testing was relatively normal. Albumin was low. CBC was fine. But then his NT-proBNP was really markedly elevated, over 12,000, and his troponin I similarly was very elevated at 0.58. So at this point in the assessment, it was unclear what really the severity of his aortic stenosis was at this point, but there was concern for an infiltrative cardiomyopathy, especially amyloidosis, based on all the cardiac imaging findings. And so the a technetium pyrophosphate scan was ordered along with an SPEP with immunofixation and serum-free light chain levels. So here are the results of the technetium pyrophosphate scan. We see three kind of planar views here. We have anterior, LAO, and lateral views. You can see the heart here as clearly as increased uptake that's greater than the uptake in the ribs. And so because of that, we call that grade 3 cardiac uptake. The radiologist did also measure the heart to contralateral ratio. So basically they take a region of interest over the heart and compare the intensity of signal uptake over the as compared to the contralateral area of the chest. And that ratio was 1.88. Which is higher than the 1.5 cutoff, which is indicative of TTR cardiac amyloidosis. And so this report was interpreted as positive for TTR cardiac amyloidosis. And then finally, I want to review the monoclonal gammopathy testing. So the SPEP did come back with a free lambda light chain monoclonal protein. And then the serum-free light chain was also quite abnormal. There was a kappa predominance of light chains with a kappa lambda ratio of 2, which is greater than the upper limit of normal. So that's our case that's going to generate some discussion today. And this is what I've outlined for us to talk about. So we want to focus on cardiac amyloidosis and aortic stenosis for the next hour or so. We'll first go over some of the epidemiology and then try and identify some characteristics that separate the patients with amyloidosis from those with lone AS. And then I'd like to take just a brief segue to go over some of the nuances of the use of bone scintigraphy to diagnose cardiac amyloidosis, because I think that there's some important room for practice improvement to make sure we're all doing that correctly. And then finally, we'll finish up talking about outcomes with aortic valve replacement. So first, talking about the epidemiology, I think this is clearly a very current and relevant topic because just in the last few months, there were 2 publications. These are both 2020s that came out in the European family of journals. So on the left here, this came out of the group from London, Dr. Moon's group, and they looked at 200 consecutive patients that were referred for TAVR For all of these patients, they screened them with echo, ECG, and a PYP scan, and then the TAVR team was then blinded to the results of the PYP scan. And using this approach, they found 13% of patients that were being referred for TAVR actually had TTR cardiac amyloidosis. So that's a pretty sizable proportion of that patient population. On the right here, this was a very similar study that was done by a group in Austria. They looked at, again, close to 200 patients that were scheduled for TAVR. So, so a little bit different from the group on the left. For these patients, they again screened everybody with echoes, ECGs, and the PYP scan, but interestingly, they were also able to get cardiac MRIs in a very large number of those patients. And they found an 8% prevalence of cardiac amyloidosis in these patients scheduled for TAVR. Now, I think a lot of times when we think about aortic stenosis and cardiac amyloidosis, we're really thinking about TTR amyloidosis. But in this study, they actually did find one patient that had AL, and I think it's really fascinating that they were so rigorous as to do an RV biopsy for all of the patients who had a positive free light chain. And you know, we'll hopefully talk more about this later, but I think that probably is the most rigorous way to go about it, because you know you're going to find some patients with AL if you do that. So so yeah, I think you can kind of conclude that probably it's about a 13% prevalence of cardiac amyloidosis in these TAVR referrals. And there was an earlier study out of Colombia that came out in 2016 that kind of found a prevalence of 16%. So I think we're kind of in the same ballpark. So now, now the question becomes, you know, how do we tell which patients actually have amyloidosis among these patients referred to TAVR clinics? So the British group looked at their data, and they compared, you know, a number of parameters between the patients with AS and amyloid and the patients with AS alone. And they found that the patients with cardiac amyloidosis tended to be older. They tended to have lower quality of life, lower QRS voltage, increased wall thickness, increased LV mass, and decreased mitral annular S prime. So, you know, we're used to thinking about mitral annular E prime, which is the diastolic tissue Doppler velocity. This is the systolic mitral annular velocity. And this was also shown in the Columbia study as well. They also found a lower voltage to mass ratio, as well as higher biomarker levels. So the NT-proBNP and the troponin T levels were higher. So, Dr. Cotter, what do you think about these parameters? You know, you see a lot of AS patients in clinic. Are these things that you look for that kind of trigger the cardiac amyloid diagnostic workup for you?
You know, I don't think we specifically look at, you know, the S prime or, you know, these specific characteristics that are displayed, but I think it's just an overall picture, you know, looking at the patient, physical exam, plus some of the echo characteristics like you showed in the patient example, is really thick ventricle with low voltages. You know, if they have perhaps their strain imaging is abnormal. So I think those are some of the things that we currently focus on in our valve clinic. And, you know, all patients who present with paradoxical low flow, low gradient AS, they're screened a little bit more vigorously for amyloidosis. But, you know, the issue with the quality of life parameters is that frequently a lot of the aortic stenosis patients have, you know, poor quality of life because of symptoms, or they may have a low 6-minute walk because they're older and perhaps frail. So some of these are, you know, confounding variables, I think, when we assess patients with AS.
Yeah, and I think, you know, one thing you had brought up to me previously was this issue of QRS voltage. I mean, we in the amyloid space are always thinking about QRS voltage, but in the AS population, you know, you've mentioned that a lot of these patients have COPD or other reasons to have low QRS voltage, so maybe in the real world is not as helpful.
Right, right. And like you said, there's a lot of confounding variables, and you just have to kind of put everything together. If there is a high suspicion for cardiac amyloidosis, then you do a further workup.
Yeah, I think the other part that I would mention, obviously, you've discussed in detail the EKGs and the echoes, but when your biomarkers are abnormal, then the red flag needs to go up. So when your troponin and your NT-proBNP are particularly high.
Yeah.
So I think the
Right.
NT-proBNP by itself may not be all that indicative of amyloidosis in somebody who has AS, because it may just be reflecting the AS. But when the troponin starts to become abnormal as well, then that's usually a big factor.
Yeah, unfortunately, we in our TAVR clinic, we check NT-proBNPs and troponins frequently, and they're abnormal in several patients. The majority of patients, I would say. So again, it becomes a little bit tricky to just raise the flag on any high troponin or proBNP. And again, you just have to take everything into context and do a further workup.
So, in a later paper, we're gonna talk more. They had also mentioned this issue of low flow, low gradient AS being kind of a red flag for amyloidosis, but actually in this paper, they really didn't find a statistically significant difference in low flow, low gradient AS. What do you think about that, Dr. Cotter?
Yeah, I noticed in this paper, again, the numbers are small in this particular study, but the mean aortic valve gradient was in the 30s to 40s,
Yeah.
Which again would explain why these patients got a benefit from TAVR because their gradients are high.
Mm-hmm.
Now, in the paradoxical low flow, low gradient AS, and especially when you're talking about gradients in the teens, there is TAVR literature out there that there's not as much benefit when your gradients are very low and you place a TAVR in these patients, because you essentially, drop their gradient from 15 to perhaps 5. So again, this particular study, the gradients were high and patients, looks like they got a benefit from TAVR. But again, you have to, there's a lot of unknowns. There's not that much literature out there showing what happens to the paradoxical low flow, low gradient AS patients with very low gradients, amyloid, and amyloid who undergo TAVR.
Mm-hmm. Okay. Great, thank you. So then moving forward, this is similar analysis from the second study, the Austrian study. And so they presented this as ROC curves. And so the parameters that they found to be most helpful to discriminate for cardiac amyloidosis were stroke volume index, voltage to mass ratio, extracellular volume by cardiac MRI, and then the myocardial contraction fraction, which is a ratio of the stroke volume to the myocardial volume and is generally lower in cardiac amyloidosis. But as you say, I think this might be more, perhaps maybe less practically useful in the clinic, but certainly interesting from a study standpoint. So last year there was actually a really nice review on this topic in JACC from the group in Quebec, and it's really nice, but just with how quickly the field is moving, it is now a little bit outdated. But they kind of raised some of these red flags that would raise suspicion for cardiac amyloidosis, and then suggest, once those red flags are raised, moving on to then confirm the diagnosis of cardiac amyloidosis. And you can see here that the bone scintigraphy really plays a key role in how we are now working up cardiac amyloidosis. And I think there are a lot of important nuances in how to do this. So I want to take a little bit of a digression away from the aortic stenosis part of things, but spend some time focusing on how to use a pyrophosphate scan to work up cardiac amyloidosis. So as many of you already know, the technetium pyrophosphate scan is a nuclear medicine study where a technetium-labeled tracer is injected into the patient. The technetium-labeled tracers are historically bone tracers, but for some reason, they seem to localize to cardiac TTR amyloid deposits. The study is graded on, it can be graded on a qualitative scale called the Perugini scale. And so if the uptake in the heart is significantly greater than bone, specifically rib bone, then we consider that to be grade 3. If the uptake is about the same as bone, then we call that grade 2. And then if the uptake is less than bone, then we call that grade 1. And then if there's no uptake at all, we call it grade 0. And then there's also the other method of using the heart to contralateral ratio, which we talked about earlier, that can also be used to help determine whether a test is positive or negative. So currently in clinical practice, we consider a grade 2 or a grade 3 study to be positive for TTR cardiac amyloidosis. And really where this came from was kind of this seminal paper that came out in Circulation in 2016. And this paper really kind of elevated bone scintigraphy into the category of diagnostic testing for TTR cardiac amyloidosis. I think a lot of us are guilty of kind of just skimming over the abstract and kind of coming to our conclusions from there. But I think this paper is one where it's actually kind of important to delve a little bit deeper into the specifics to really understand what they found. So from the abstract, you can see that their findings are really pretty remarkable. So the positive test was 99% sensitive, 86% specific, and then we can even bring the specificity up to 100% if we add monoclonal protein testing. Very importantly, they did look at a very large number of patients, over 1,200 patients. Notably, these were all patients that were evaluated at specialty amyloidosis centers in Europe. And of those patients, only 374 actually had diagnostic confirmation by endomyocardial biopsy. So, certainly it can be extremely suggestive if an extracardiac biopsy is positive and the cardiac imaging is positive. But I guess to be a purist, you would say that really we only really know in 374 patients. So just to dive a little bit deeper into the specifics of the study. So, this 99% sensitivity that they quote, this is for any positive scan. So grade 1, 2, or 3. And if you look at the specificity with this positive scan definition, it was really only 68%. So a lot of false positives if you include the grade 1s. To bring the specificity up to 87%, we have to restrict to only grade 2 or 3 scans. But then if you only look at grade 2 or 3 scans, the sensitivity goes down to 91%. And then, of course, adding the monoclonal protein studies, if you have a grade 2 or 3 scan and no evidence of a monoclonal gammopathy, then the specificity is, was 100% in this patient population. So again, just kind of highlighting how important and current this topic is, there was just a JACC review topic of the week that came out within the last 2 months that was specifically trying to highlight some of the potential pitfalls with the use of bone scintigraphy to diagnose TTR cardiac amyloidosis. And this is a really, really practical and useful review that I would highly recommend anybody with an interest in this area to review. They go over several causes of misdiagnosis that can occur with bone scintigraphy, and we'll go through these, now. But first is the failure to exclude AL. So, the very high specificity of the PYP scan is really only when you exclude a monoclonal gammopathy. Secondly, they talk about failure to use SPECT imaging as a notable cause of misdiagnosis. And then they also mention other causes of positive scan that we need to be aware of that may kind of lead to a misdiagnosis. And I think that these last 2 points here are especially important as we start to use the bone scintigraphy more broadly outside of specialized amyloidosis centers. those are patients with very high pretest probabilities for cardiac amyloidosis. And so as we start to use this more in the general community and in private practices, we're going to be scanning different types of patients. And so we may end up picking up different causes of positive scans. So the first thing that I want to talk about is how to screen for AL. And so how we do that on an initial basis is to send an SPEP with immunofixation, a UPEP with immunofixation, and then the serum-free light chain assay. And the immunofixation is added really to improve the sensitivity of these protein electrophoresis tests. So in terms of how to interpret these tests, ideally, if you're trying to diagnose TTR cardiac amyloidosis, your free light chain ratio would be normal and there would be no monoclonal protein. And I think if that's the case, you have a positive PYP scan and your other cardiac imaging is very consistent, I think you can be quite confident that your patient has TTR cardiac amyloidosis. The tricky part comes around when any one of these tests is abnormal. And really, I think in that situation, they say here that tissue is required to make the diagnosis, and I would agree with that. It's important to note that the serum-free light chain ratio actually can vary by renal function. And so the normal range for at least our assay we use here at WashU is 0.26 to 1.65, but in patients with renal dysfunction, this kappa lambda ratio can actually be as high as 3. And so it can get tricky to sort out whether an abnormal free light chain ratio is due to renal dysfunction or potentially a monoclonal gammopathy. But I think a common mistake that cardiologists make is just to order the PYP scan without thinking about checking for AL. And that can be an important cause of misdiagnosis if not done correctly. I don't know, Dan, if you have anything to add about that.
No, this is a beautiful presentation. I agree with everything you said.
A quick question for you. So this is Isaac Ray with down in Memphis. I've been trying to do this for some of my patients, and it's not uncommon for me to get an elevated light chains, but the ratio is okay. Do you do anything with that in particular?
If the ratio is okay, I actually don't pay too much attention to it. I have the luxury of having an oncologist kind of easily accessible by email, so I can always run things by him. But it's generally the ratio that I tend to pay most attention to.
So Isaac, this gets really confusing when you start digging in the weeds, but for the most part, it would be the fourth on the list of table 4 from Katie's slide. So if your ratio was basically normal, but both lambda, kappa and lambda were elevated and the ratio was acceptable, and you did not see a monoclonal protein, then most of the time we attribute that to renal dysfunction. But you have to look at all those other factors. But if there's no monoclonal protein seen, then that's a pretty negative test.
Okay, great, thanks.
Great. So then the next thing to talk about is this issue of the SPECT imaging. So this is a patient who actually, this is from their review paper here, had a dilated cardiomyopathy. Wall thickness was pretty normal, about 1 centimeter. EF was 30%. For some reason, someone suspected cardiac amyloidosis and did a PYP scan. And you can see on this planar image that there definitely is increased uptake in the region of the heart. And so this patient was started on tafamidis treatment. Again, for unknown reasons to me, they went back and did SPECT imaging on this patient, and it turned out that actually all of the tracer uptake was within the blood pool in the LV cavity and not in the myocardial tissue itself. And so now in the nuclear medicine guidelines, they actually specify that we should be trying to avoid planar imaging and that all these patients should be getting SPECT to ensure that these types of false positive results don't come up. I think this also really drives home the point that we need to be, selectively utilizing this test in patients who we are actually have other reasons to suspect amyloidosis in. So, this patient here was dilated cardiomyopathy who, didn't have kind of classic echo findings. So this is just this whole issue of blood pooling of tracer is an important caveat for us all to be aware of. And then, other causes of positive scans are really kind of reported as case reports as of yet. There was a really nice case of hydroxychloroquine cardiotoxicity showing up as a positive PYP scan that came out of Mayo a few years ago. Blood pool uptake and AL we talked about just now. Here at WashU, we had our own case of a false positive PYP scan a few years ago. This was a young lady who had a long history of renal failure with multiple failed renal transplants, who had developed progressive heart failure and then also VT requiring ICD shocks. And on one of her last hospital admissions, there was a lot of suspicion for cardiac amyloidosis actually, because, you can see that her walls were very thick. On her strain imaging, she had a very classic apical sparing pattern of longitudinal strain. And then she did end up undergoing a PYP scan. You can see there was markedly increased uptake in her heart as compared to her bone. We did not pursue a cardiac MRI for this patient because of renal dysfunction, and unfortunately, she ended up dying, soon after this. But interestingly, at autopsy, we found her not to have amyloidosis, but actually she had extensive calcium deposition throughout her myocardium. And it was in a pattern that was consistent with primary calcification. So we thought this was due to a long-standing history of renal failure with dialysis and long-term Coumadin use. Here in the gross specimens, you can see that you can actually see the calcium deposition, and it's really fascinating that it really spares the apex and is most predominant in the base, and then less so here in the mid cavity, which is kind of how we think of the amyloid deposition as well. So like I said, I think as we start to use the scans more, we're going to be finding more and more of these kind of alternate causes for a positive study. All right, so now let's go back to our case. So where we left things, our patient had paradoxical low flow, low gradient AS. He had grade 3 uptake on a PYP scan, but he also had an abnormal free light chain ratio and a positive free lambda light chain. So I'm curious as to how others on the call would have handled this study. I know how we did it, but does anyone have an opinion on how they would have dealt with this at their institution?
Katie, I think this is a patient I saw in clinic.
Yes.
And, fortunately, we have a very strong cardio-onc program, so I sent this patient to you guys.
Yes. So we're going to talk a little bit more about this later, but we ended up sending this patient for an endomyocardial biopsy. I think it is so critical to make the correct diagnosis for these patients because the treatment for AL and TTR are so different. So here at WashU, we are quite aggressive about sending our patients for cardiac tissue whenever there's any question, and we're very lucky to be supported by a very strong heart failure program that makes that feasible and safe. So this patient did end up going for a cardiac biopsy. And in terms of his pathology results, you can see here on regular H&E staining that there's, so these darker red cells are the cardiomyocytes, and then in between them we see this waxy pink amorphous material that's deposited all around, and that's the amyloid deposits there. When we stain with Congo red, we see that that waxy material is stained again, but then the real money shot was here under polarized light. The Congo red staining actually turns apple green with birefringence, so that's really what's classic for amyloidosis. So here, our pathologists always perform immunofluorescence on these studies, and unfortunately, I could not obtain the slides from our patient. So these are slides from another patient, and this is a kidney biopsy. So those are glomeruli, but the point is the same for both patients. So there was no uptake for when they did kappa staining on immunofluorescence. But then with lambda, there was really strong immunofluorescence uptake. And it's really interesting because, you know, our kappa lambda ratio was skewed in favor of higher kappas, but it was really the lambdas that were showing up on the immunofluorescence. So based on these findings, our pathologists were more suspicious for AL amyloidosis as opposed to TTR. We did still send off the tissue for mass spectrometry, which is our practice here. And when the results came back several weeks later, it did confirm that this was in fact TTR amyloid deposition all along. They did not find an amino acid sequence abnormality, and we confirmed that the genetic testing was also negative for gene mutation. So this patient had wild type TTR amyloidosis, and we ended up starting him on tafamidis. So I think this issue with the immunofluorescence, you know, merits really further discussion, because we've shown this case to several cardiac pathologists, and you know, they were really interested to see that the immunofluorescence was, you know, was positive for a TTR amyloid case. And I'm not sure if that's really been described in the literature, but we definitely need to get it out there that you shouldn't just hang your hat on the immunofluorescence to call light chain amyloidosis. So then just to summarize what to do with these light chains, you know, if you have a positive scan and you have totally normal serum testing, then I think we can go ahead and treat for TTR. But if any of these things are positive, if the testing for monoclonal gammopathy are abnormal, then, you know, our practice here has been to biopsy an involved organ. You know, sometimes in some cases we have just sent patients to oncology to do bone marrow biopsies. And, you know, in a best case scenario, the bone marrow biopsy would be totally normal, and then you can rule out AL. I think that the really sticky situation comes where, you know, the bone marrow biopsy shows 3% plasma cells and no amyloid deposition. So you're still not quite sure if it's an MGUS or if it's AL in that situation. And so I think probably biopsying an involved organ is the most rigorous way to go about it. Do you have thoughts
Katie,
on that,
just,
Dan?
yeah, this is, you know, this is a great example, and you've really expertly summarized it. But the bottom line is that, so you did go to a biopsy, and the biopsy pointed in one direction, and it wasn't until you did mass spectroscopy that you actually confirmed the true diagnosis. And I can tell you that this patient was already scheduled for chemotherapy when we finally got the mass spectroscopy back.
Mm-hmm.
And so we had to cancel his chemotherapy, which was going to happen the next day. So I think that, you know, when you go strictly by what a pathologist reads, for example, on the biopsy at one institution, you still have to confirm the presence of fibrils. What type of fibril is present? That's absolutely necessary.
Mm-hmm. Yeah, I think this case really highlights the complexity there. Okay.
And in a previous institution, we've had instances where people even went through chemo and a stem cell transplant and ended up with hereditary TTR. So I think that, you know, we really don't want to repeat those types of decisions.
Mm-hmm.
Hey, this is Courtney Campbell from Ohio State. I was wondering, do you guys ever, when this type of patient comes into our clinic, we're based out of the our cancer hospital. We often just do a fat pad biopsy as a first step in clinic before we schedule for something like a endomyocardial biopsy. And if we do get protein, then we'll send that for, you know, pathology and mass spec, and we always rely on mass spec. Is that part of you guys' workflow?
I'm curious, what is your yield with the fat pad biopsies?
It's not maybe 30 to 40%. We don't do it that frequently, but if we do get it, it saves them a more invasive procedure.
Mm-hmm. Yeah, we don't do that here, and I think our feeling is really that your yield is going to be highest if you go after an involved organ. So yeah, we have not incorporated the fat pad biopsy into our protocol.
Thanks.
Yeah, I think that, for example, Mayo Clinic, I believe that they have a lot of confidence in their fat pad biopsy technique, and I imagine that they've, pioneered the whole approach via fat pad. So I think that the workflow that you're describing is probably very consistent with what happens at Mayo Clinic, but we haven't really had that same experience. And besides, for example, in these patients that are getting a TAVR evaluation, they're going to be getting a right heart cath anyway. So we don't really see the biopsy as a big deal.
Okay.
Have you seen any patients that have had both AL and TTR at the same time?
Yeah.
we came pretty
We had
close.
one, right? Didn't we have one a couple of months ago?
Well, he came very close. So, we were sure that he had some sort of amyloidosis, but we weren't sure which one. And he ended up getting genetic testing, serum genetic testing done. He had the V122I mutation in the TTR protein. He then got a bone marrow biopsy and had rip-roaring multiple myeloma, greater than 10% plasma cells. And so then we were really stuck. And in terms of what to do, and ultimately we had to rely on the mass spec to tell us what the amyloid protein was, and it ended up being TTR. But I can't say that I've seen a patient with, TTR and AL amyloidosis at the same time. I think that would be extremely rare.
Yeah. I was wondering if it sounds like the mass spec can differentiate between the two, though, even if they're two are coexisting.
Yeah, that's the most specific technique. It's, and they can't always do it. So if they have a biopsy that only has a little bit of amyloid, they may not have enough tissue there to distinguish. But if they do have enough tissue to distinguish, then it's very accurate in terms of defining the fibril type.
This is Courtney again. What's your experience with, do you guys ever have false positive biopsies or false negative biopsies? More false negatives, I guess, is the question.
That's a really great question, and it's tough because we're using the biopsy as our gold standard, right? So we have had cases where patients who, looked and smelled like cardiac amyloidosis, and every other way had negative biopsies. In fact, one patient was biopsy proven by kidney, and then had, very consistent MRI and echo findings, and then he had a negative cardiac biopsy. So definitely that happens. I think in that patient's case, we still kind of just treated him in our minds like he had cardiac amyloidosis. But you bring up a really good point, that could be an issue.
I think the main point from your question would be there is no perfect test. So I think in the end, a lot of times you have to put all the pieces together.
This is Lauren Baldessari from New Haven. Really great presentation. Hi, everyone. I just wanted to mention for cardiac MR, if the site and the machine has the capability of T1 mapping, that even if the patient cannot get contrast due to severe renal disease, they could still get native non-contrast T1 mapping to help with the diagnosis. It's not a perfect, science, but if you have a really high T1 value, that's incredibly helpful to make the diagnosis, especially if you're also, depending upon the clinical scenario, trying to distinguish between other, diseases that cause LVH, for example, even like Fabry's disease, where the T1 map would be very, very low. So even when you can't give contrast, it's still something, if you have that capability, to consider. We had shown in a case that we published that the T1 values with treatment with the patient actually decreased, and then others have shown in larger cohorts that that's also a value that can be used potentially to mark, response to treatment.
Yeah, thank you so much. And I think we need to, here at WashU, it's our radiologists do our cardiac imaging, and we probably need to sit down with them and talk to them about incorporating that T1 mapping into our cardiac amyloidosis studies, because to my knowledge, it seems like they're still really relying on the contrast here. I don't know if you know differently, Dan.
No, I agree.
Okay, wonderful. Thanks all. So let's move on into the last section of the talk and just talk about how to manage the aortic stenosis in these patients. So referring back to that, the JACC review from last year, they had kind of this nice flow diagram for how to work up and deal with the aortic stenosis in our cardiac amyloidosis patients. They also talk about the higher prevalence of low flow, low gradient AS here. And they really felt in this review that a calcium score would be most useful to assess AS severity. And, they talked about, with dobutamine stress tests, that how amyloid patients just don't augment their stroke volume as well. Dr. Cotter, what do you think about this approach to evaluating AS severity in the cardiac amyloid patients?
So I think we do use a very similar approach in our clinic. When we see patients with paradoxical low flow, low gradient AS who have other echo findings too that are suspicious for amyloid and clinical findings, we end up getting a calcium score to determine if they do have severe AS or not, but we do end up kind of escalating the workup, and depending on what that shows, then place the appropriate referrals.
Okay. And then they go on to talk about different therapeutic management options for AS. And so now we'll kind of move in and talk about some of the studies we have looking at outcomes after valve replacement in our AS patients. So this was actually for a long time the only data that we had until those two recent papers I mentioned earlier. This was again out of the British group in London, but this initial publication was looking only at patients who underwent TAVR. And these were patients scheduled for TAVR who underwent intraoperative septal biopsies during the TAVR procedure. And they found a 6% prevalence of wild type TTR using that approach. But clearly we can see that the patients with cardiac amyloidosis really had worse survival over 2 years of follow-up. I think for a long time, this kind of tempered everyone's enthusiasm about being more aggressive for patients with AS and amyloid. So then, just in those two recent TAVR publications, the outcomes that they found were actually much more encouraging. They found that there were no differences in TAVR outcomes for the amyloid patients here in red as compared to the lone AS patients, and this was over 19 months of follow-up. And then comparing between TAVR and medical therapy for each group, they also found significant benefits with TAVR as compared to medical therapy. So here in the blue and the red, these are the patients without cardiac amyloidosis. So clearly, if we put in a TAVR valve, those patients did better. The The same was also true for the cardiac amyloid patients. So here in green were those that got medical therapy, and in orange were those that got TAVR. And so in this group of patients, the TAVR clearly improved outcomes. These are the same kind of outcome charts for the Austrian study. Again, no difference in all-cause mortality over 15 months of follow-up, and no difference in cardiovascular hospitalization. So, Dr. Cotter, you kind of already talked about your take on this, but how do you interpret these things, these findings?
You know, in general, I do think that the number of patients in these studies is small. And I think that, again, you have to, look at these studies and look at how many patients had high gradients versus low gradients. And I think that could potentially make a difference in outcomes when you're treating with TAVR. So I'm not sure if you have those numbers kind of parsed out in these studies.
Yeah, I think we had looked at that big table 1 earlier, and you had even pointed out that the mean gradients were, high 30s on a median for the amyloid patients. So clearly it was a group with higher gradient AS.
Yeah. You could justify, when we're seeing patients with cancers in our TAVR clinic, in our valve clinic, we always try to get a prognosis, a sense of prognosis from the oncologist. And, one of our metrics is the 1-year survival. If they have a decent 1-year survival, then, just so that they can get through their treatments and get symptomatic relief, we might offer them TAVR. But really, we kind of pick and choose patients too. And the high gradient patients may benefit more from relieving that obstruction. And there's very limited data on what happens to the low gradient patients, especially when you're talking teens and 20s sort of grade.
Yeah, Nishath, I would also add, I think you're probably right, or I suspect that you're right on the whole high gradient versus low gradient. But the other thing I would wonder is in patients with significant EKG abnormalities consistent with amyloidosis, to me that usually at a minimum implies more general infiltration, and maybe those patients coupled with a lower gradient should not be referred for TAVR, whereas people with a high gradient who maybe didn't have low voltages or other EKG findings, then they would probably benefit from TAVR. I don't know if there's been any data to really sort of sift those things out or not.
Yeah, unfortunately, again, the data on aortic stenosis and amyloid patients is limited, with limited number of patients in the studies. But our general rule has been to we look at the overall patient, obviously get a sense of prognosis from their oncologists. We have been shying away from offering TAVR to patients who have cardiac amyloid. But it probably is also because a lot of the patients that are presenting to us have low gradients, and in general, have really bad diastolic heart failure with renal disease and, all the other things that come along with amyloid.
Great.
And is this data, is this going to shift what you do with your patients, you think, or are you still waiting for more data?
Sorry, is that question?
Oh, for Dan. That was for Dan.
Oh, yeah, no, I just think, Nishath, at least at WashU, Nishath is basically the person that's going to be seeing these patients. So I think that if she has any suspicion of amyloidosis, then we want to be involved. But how to sift through all of those decisions, I don't know. I don't know the answer. So
yeah,
I think in our, again, there's really no right or wrong answer at this point because there's so much that's unknown. But if I were seeing a patient and I work the patient up and the patient had cardiac amyloidosis, I really would have to put everything, the clinical risk factors of the patient in context of everything. If the patient has really high gradients and is extremely symptomatic, and I can get a sense of from the oncologist, and if I can get a sense of prognosis for the patient, then one could argue that you can treat the patient, treat the patient's aortic stenosis, for symptomatic relief, and so that they can have their treatments. But again, when I just get a little nervous when they have very low gradients, because it just tells me that they have, perhaps like Dan was saying, that they may have advanced disease. And I don't know what the benefit is of replacing their aortic valve.
Yeah. So just to wrap things up with our patient, we elected to proceed with medical therapy for his aortic stenosis, and he was continued on tafamidis. Unfortunately, he did pass away just 8 months after this initial TAVR clinic evaluation. And I think part of this just goes back to the point which we've all been talking about for a long time, which is we need to be better about, diagnosing these patients earlier in their course so that we can, intervene before things really become too advanced. So I know we're coming up on the end of our hour, so I just want to leave you all with some concluding thoughts. I think it's really important, as always, to maintain a high index of suspicion for cardiac amyloidosis, especially in our patients with AS. When ordering bone scintigraphy for the workup of TTR cardiac amyloidosis, it's critical to check for a monoclonal protein. And when in doubt, if there's any question, endomyocardial biopsy is really the gold standard for diagnosis. But although, as we've talked about, there's no perfect test. And then, TAVR may be an option for our patients with amyloid and severe AS, especially those with higher gradients. And so we appreciate the support we have from our valve service here. And with that, I'll take any additional questions.
I have a question. I'd like to ask Ms. Zhang. What do you think about doing a balloon valvoplasty in these cases where you really can't decide what to do? If it's successful, which it often but not always is, you'd see immediately that there would be a improvement, in terms of how they felt, like the next day or so. And that could help with your decision making. Have you ever thought of doing that?
Yeah, so in our valve clinic, we do offer valvuloplasties, but again, it depends on if we think that ultimately the patient is going to get a benefit out of, valvuloplasty. As you know, valvuloplasties carry their own risks. It's not trivial. I mean, there is a risk of stroke and rupture of the annulus and all sorts of things. So I think that you could, we have offered valvuloplasty to patients who have active cancers, who need to undergo some sort of therapy. So then it's sort of like a bridge to decision of whether we need to treat with TAVR. But again, we have to kind of look at the overall picture. Like in this particular case that Katie presented, this patient was extremely debilitated when I saw him in clinic. He, I think, had a couple of hospitalizations. He was wheelchair bound. I mean, he just, his creatinine is already 3, his gradient's 15. I mean, even with a valvuloplasty, you can, you may change the gradient a little bit, but it's not going to change that much from 15, because 15 is already pretty low. So I think that we kind of took that.
Basically, he failed your eyeball test.
He failed the eyeball test, and he really, I mean, the low gradient patients will not gain much benefit from a valvuloplasty because you're not going to change their gradient significantly. I mean, valvuloplasty doesn't make your gradient 0. It may drop your gradient from 15 to, perhaps 8 or 7. So, you know, you really have to be careful when you're offering valvuloplasties also. We have done that, but it's for, you know, again, you have to sort of take that into consideration that, you know, it's sort of like a bridge to decision for these patients. And they have to have higher gradients, and you have to be sort of sure that it's, you know, relieving that gradient is going to help them get through whatever they need to get through.
Great. Thank you so much. What a fantastic presentation, Katie. Thank you, Nishath, for joining in and all the comments from others. We appreciate your attendance. Steve, do we have one next week, or is that like the 5th Thursday of the month?
Yeah, next week we are off, and then August 6th we'll pick back up with the Journal Club.
Great. All right. Well, thank you all for attending, and Katie, again, a fantastic presentation.
Great, thanks so much.
Thank you.
Thank you.
Everybody.
Thank you.
Thank you.
Thanks, everyone.
Thank you.
Nice.